A pleasure to welcome our speakers today, and we have 4 speakers, and I'll let them introduce themselves as they hand over the baton. But we have a very interesting talk today, and I think very relevant to our surgical practice. And just briefly, we have Dr. Raven Dumont-Maurice, who's involved in UGME and also at the Gatineau campus. Samir, Shaheen-Hussain, Dr. Saleem, Razack, who I think everybody pretty well knows, and Dr. Kent Saylor. So I'll let people start their talk, and so we can have about 10 to 15 minutes of discussion at the end. I will be monitoring the chat through, so we'll leave questions for the end, and then I'll go through the chat and ask the questions to the 4 of you as we get going, and then one of you or all of you can pick up on the answer. All right, so welcome again to Surgical Grand Rounds. I hope it's not too early in the morning for you, but a good start to the day is always a fairly fresh thing. So welcome, and we're looking forward to your talk.
Thank you very much. So just to test, can everybody hear me? Just with quick nods. Excellent. So Kwe, welcome everyone. Thank you for attending this morning. My name is Dr. Dumont-Maurice, and I'll introduce myself a little bit more fully as we go through. We would just like to begin by acknowledging that the land upon which we work, live, and play is located on unceded Indigenous lands. The Ganengehaga Nation is recognized as the custodians of the land and waters on which we gather today. Ojage, or Montreal, is historically known as a gathering place for many First Nations, and today it is home to a diverse population of Indigenous and other peoples. We respect the continued connections with the past, present, and future in our ongoing relationships with Indigenous and other peoples within the Montreal community. And so together, we will be presenting Jordan, Joyce, and Justice, Decolonizing Healthcare in Surgical Education and Practice. And many examples that we will share today do pertain to the pediatric population, as we're all pediatricians by training, but the themes and messages are really universal to patients in healthcare and the healthcare system in general. I will just go through the objectives as a reminder. And so we hope to, through our talk today, help the listeners recognize the healthcare system as a key site of anti-Indigenous systemic racism, to understand the importance of critical consciousness as healthcare providers to confront medical colonialism, and to develop tools to work towards decolonizing healthcare in surgical education and practice. And so before introducing myself more fully, I would like to introduce the individuals referenced in our title so that we are familiar with their stories. Starting with Jordan River Anderson, who was a Cree child whose parents were from Norway House Cree Nation in Manitoba. He was born in Winnipeg Hospital in October of 1999 with Carey-Feynman-Zitter syndrome, which is a rare congenital myopathy. Jordan was ventilator dependent, and his condition was deemed too complex to be treated on reserve. At the age of 2, he was approved for home-based care and had a foster home in Winnipeg that was ready to accept him. However, prior to being discharged, he required equipment and adjustments needed to be done in the home. And since Jordan was a First Nation child, jurisdictional disputes between the provincial and federal governments occurred thereafter. The governments could not come to an agreement as to who would incur the costs of home care. And Jordan died in hospital in 2005 at the age of 5, never having gone home. A tragedy that would have never occurred if Jordan was a provincial child. And so Jordan's principle is a child first principle that now exists and states that any services that a First Nation child may require should be taken care of by the government of first contact, and details of funding should be sorted out at a later date. And for interest of time, we won't go through the details of how Jordan's was ultimately passed and later what it took for its continued implementation, but it proved to be an arduous task. And you may have heard more recently of Joyce Echaquan. So Joyce Echaquan was a 37-year-old mother of 7 from the Atikamekw Nation of Manawan, north of Joliet. Joyce sought help at the Joliet Hospital and was subject to vicious treatment by the healthcare personnel there. And in her final moments of agony, Joyce filmed the video and posted it to Facebook Live. She passed away shortly after in hospital on September 28th, 2020. And we don't know how Joyce had the strength or the headspace to film the injustice that cost her life, but she did. And in doing so has highlighted the ugly truth of what systemic racism can do in our healthcare systems. And without her courage, we would not be meeting here today. And Joyce's family, the Nation of Manawan, as well as the Atikamekw Nation, following Joyce's death, put forth and proposed Joyce's principle to the government of Quebec. And in short, Joyce's principle aims to guarantee to all Indigenous people the right of equitable access without any discrimination to all social and health services, as well as the right to enjoy the best possible physical, mental, emotional, and spiritual health. Joyce's principle requires the recognition and respect of all Indigenous peoples' traditional and living knowledge in all aspects of health. And it puts together concrete recommendations in 6 different areas or pillars, and one of those being recommendations for teaching institutions in the health field. And I would invite anyone listening to consult the document. I'll put the link to the website in the chat. I forgot to do that this morning. And of note, Joyce's principle was not accepted by the provincial government, mainly on the basis that the province continues to deny that systemic racism exists in the province of Quebec. And so, as I mentioned, my name is Raven Dumont-Maurice. I'm a member of the Algonquin Nation from Kitigan-Zibi, Anishinaabe, which is about 4 hours north of Quebec, and that's an aerial view of part of the reserve there. And I would like to share my story with you today, a little bit of my journey going through medical school and beyond. And in doing so, my goal is really to share knowledge and not point fingers, but rather point out systems issues that I've came across. And certain things that will be shared may be hard to hear, especially if there are Indigenous people in the audience. I just wanted to give a fair warning for that. I started medical school in 2008. The first year that a new program in Quebec called the Quebec First Nations and Inuit Faculties of Medicine program came to existence. And so in 2008, 4 extra spots were allotted across the 4 faculties of medicine in Quebec. And in the pilot year, 3 of those 4 spots were filled, and the program is still very active. I believe there are on the order of 50 or 60 students admitted and since graduated through the program. I should have checked the numbers, but we can verify with Kent if that's accurate. I believe so. Moved on to residency in pediatrics at the old at the Children's, and ultimately graduated in 2016. And since then, I've been working a little bit all over. Went to Ottawa a little bit. Now I'm mostly in Montreal and work in Ganastake as well. And so just wanted to go through. So this picture was actually drawn by one of my friends who's from the community, Hunter Dawashi. He's an Anishinaabe Two-Spirit artist, and I just wanted to say thank you. And I always include this slide because it amazes me that what I was starting in 2008 was not always a possibility for a First Nation person in this country. And it's not clear how long the practice was in effect, but there was a time that a First Nation student would have had an identity crisis upon graduating, because the Indian Act stated that a First Nation person graduating from university, becoming a doctor, becoming a lawyer, immediately revoked that individual of their native status as one of the many forms of enfranchisement that occurred in Canada. And laws like these existed until relatively recently. And so thinking about this picture, the historic underrepresentation of Indigenous people in med school was very much a systems issue and intentional by the government for a very long time. And the effects of which are likely felt today and seen in the relative low percentage of Indigenous doctors across the country. And I point this out because it's not often spoken about, but often the underrepresentation is often superficially explained by stereotypes that we can see on either TV or other sources of media if we don't look closely enough. And I wish for us to keep that in mind as future med students and residents come through and evolve through our programs, because acknowledging history can go a long way in their path to becoming a doctor. And as an Indigenous person myself going through medical school, got a unique perspective on the insides of medical training, a view on the other side that most people don't get to see, and having personal stories of myself, family, friends, patients all being treated. And especially in view of recent events, I've been reflecting onto what I remember most about my training that may contribute to the state of affairs today. And what I do remember most is what I'll refer to as hallway talk that all too often goes unchallenged. And it's not a coincidence that the stereotypes that I would regularly hear have also been quoted in Dr. Marie-Hélène Turpel-Lafont's report In Plain Sight that was conducted recently in BC. Dr. Turpel-Lafont was appointed by BC's Minister of Health, Adrian Dix, to investigate racism encountered by Indigenous people in the healthcare system, after the health minister had heard about a game that was being played in the Emerge where staff would guess the blood alcohol level of Indigenous patients. And so beyond finding stereotypes, in her report, she also stresses that these stereotypes went on to cause real harm. And so these are the most common stereotypes of Indigenous people that are held by healthcare professionals. And so, I mean, as a pediatrician, one that I would hear a lot is bad parenting. And so countless times in medical school, I would hear things like, you know, parents not here, well, they must be in the park or drunk somewhere. And that was a regular occurrence. And ironically, we're going to hear about the non-accompaniment rule shortly from Samir, but it was often before the abolition of that. And so we weren't always aware of what was preventing parents and children from being together, but assumptions were often quick to come. And so this speaks to deep misunderstandings that can continue to propagate harmful stereotypes and ultimately affect patient care. And so I wish that we not underestimate the power that our words and actions can have as teachers and healthcare providers, especially to younger eyes and ears. And our new generation of medical students are benefiting from a new curriculum on Indigenous health at McGill, thanks in large part to Dr. Saylor. And so courses are mostly in the first 2 years of medical school, but continue throughout as well. And so reflecting on my own med school experience, I do have, fears that certain learned behaviors in clerkship and residency may be absorbed if our conversations don't change today. And thinking back to my training, it's really clerkship and residency that shaped me into the physician that I am today. So again, I want to stress that we can't underestimate the power that our words and actions can have. And so moving on, this is a slide, pictures taken from Camp Carawanis, which is a diabetes camp that is run by the children and McGill and affiliated with St. Justine as well. And so in a year where McGill has changed the red men to the redbirds, we can sort of tease out what's wrong with the picture. And the biggest irony to me was at the time, had a First Nation child, applied to the camp, this wouldn't have been a safe space for them. And it wasn't a safe space for a trainee either. And the irony is that through colonization, there are very high numbers of diabetes type 2 for First Nation children. And at the time at the camp, words like squaw were being freely used. How was being used as a greeting, and I was actually how-howed for the rest of my residency there after this experience. And again, I mean, we can speak to the many different forms of racism, but this refers more to microaggressions, and there was no deliberate external malice, but it was hard to believe how there were professors and students and residents, and not just no learning happening about Indigenous people, but harmful stereotypes that were being propagated without second thought. And it really got me to thinking, how many missed opportunities at Indigenous education do we have on a daily basis in our hospitals and clinics and healthcare system? And why is this so important? Why bring up things from the past? Well, it does link back to our patients and objectives of the talk, because I do believe that not challenging these ideas of the drunken Indian, the lazy Indian, the common stereotypes is extremely detrimental to every Indigenous patient's health. And very quickly, I don't want to go over time. These are, slurs heard in the video. If for those who have watched Joyce's video, I did not through curiosity, but to gain better understanding. And so it's, again, these are things that come up in the report in BC, which just reflects how systemic these problems can be. And so as long as ideas like these are, continue to be shared, and that there are safe spaces that these ideas can be shared and aren't shut down right away, what will prevent the next stretcher from going into the OR for forced sterilization? The most recently, as 2018 in Saskatchewan, there's been reports of this practice in Canada. And so Indigenous education from the Indigenous perspective, as opposed to the colonial versions that we may have had recently, is key to deeper understanding and change. And so I will leave you with these words that were spoken by Minister Haidu following an emergency meeting after Joyce Echaquan's death. And so it's not a few bad apples. It is a system that not just turns a blind eye, but implicitly endorses and reinforces its behavior many times over. And Joyce, in the middle of her deep pain, showed something that so many people would prefer to ignore. And so she gave Canada a gift that has to be honored, no matter how difficult it is to receive it. Thank you very much for listening. I'm going to turn it over to Dr. Saylor.
Thank you, Raven. And I'm going to share my screen here. And let me start this. Okay. And Saleem, I can see you. Can you see my slides? Perfect. All right. So thank you, Raven. And so I will take things over. I will try to stay on time as well. I'm going to share mostly my personal story, and you'll know a little bit more about me as we go along. So I'm a member of the Mohawk Nation, and I grew up in on the Ganawage Reserve. And for those of you who don't know where that is, it's actually very close to Montreal. It's right across the river from like Lachine and Dorval. And so from the MUHC, it's probably about 20 minutes on a good day without traffic. So very close to Montreal. And as I was growing up, I actually saw lots of racism that I'm not even sure I knew it was racism as I was growing up, and didn't really realize it. And this was mostly, it would happen very often in the sports that I was doing. I played hockey a lot, and it wasn't that uncommon to really be called down, like even from the parents in the stands. I have been called savage many times in my youth, mostly when we were, together as a group, and it would even happen on some school trips when we would leave the reserve. And what's kind of sad about it is I actually thought that was normal, that's how people were. And as an impressionable young child, I even started to believe those things, that we weren't as good as other people, we were maybe inferior. And so it really brought out to me that at that time, as a younger child, I felt I needed to blend in and try to be like, try to be non-native, so I could not be called those things. And that's how things continued for me as a young child, and then into my teenage years. And for a variety of reasons, I left Montreal in 1983 and I went to the US. And there I did a grade 12, I did a bachelor's degree. I ended up going to medical school and did pediatric residency. And interestingly, I did not get into McGill when I applied, but I had a lot of success getting into schools in the United States. I ended up going to Stanford, and I was rejected at McGill at that time. And when I went to the US, I started off feeling the same. I felt I really needed to just blend in and be like everyone else. And then slowly over that time, I realized that, well, maybe I don't really need to do that. And it wasn't so much my own personal feelings. It was really the environment where I was that really allowed that, because the peers and colleagues that I had there were very eager to learn more and open to discussion on Indigenous issues. They just wanted to learn more, and in a non-judgmental way. And I was never, I don't remember being called savage or anything like that when I would bring up some of these things. The other thing that was very important is that I wasn't alone. There were other Indigenous medical students, and there were residents that I had worked with. We didn't have any Indigenous staff at the time, but that was actually very empowering to have other people there with me. And slowly, many people, I realized, just valued the fact that I was an Indigenous person, which I didn't really feel before. And honestly, it took some time, but that was really when it hit me that, you know what, it's okay to feel proud to be an Indigenous person. It's okay to feel proud to be a Mohawk person. And the sad part about it is it really took 30 years. I was almost 30 by the time I finally said, okay, you know what, this is okay. I can talk about this, and it's okay to be an Indigenous person. So that brings me to the late 90s, and I'll share some of how things were when I came back. I decided to come back to the Montreal area, and I started a fourth-year pediatrics residency at the Montreal Children's Hospital. And things were different from where I left in the US. And actually, I say different, but it was actually, it ended up being the same as how things were in Montreal before I left. And you could just feel it in the environment and in people's discussions, or actually lack of discussions in general. I could feel it in Montreal, I could feel it in province, and kind of nationally in things I was hearing on TV and things like that. And yes, it was different where I was at the Montreal Children's. I just did not hear that same interest in learning about me as an Indigenous person. And I quickly felt that pride kind of slip away and reverted back to trying to blend in. I never hid the fact that I was an Indigenous person, but I did not feel that comfortable talking about it with even with colleagues. Now, at the MUHC and the children specifically, I did finish my residency. I did a little work in the U.S. for a bit, and then ended up starting as staff member in the year 2000. And I have worked in a few different programs. My main work has been with the Northern Native Child Health Program. I have worked in emergency room, our short stay unit, medical day hospital, medical wards, and so I've kind of done the tour at the hospital. And really, I just did not hear very little positive discussion about Indigenous peoples in general, and really saw that there was a lack of basic knowledge about Indigenous peoples across the board, whether there was a receptionist at the front desk or the nursing staff, other allied services, or physicians. A lot of people just didn't know basic things. And like Dr. Dumont-Maurice was talking about, there were many things that I heard, microaggressions, and this was mainly hallway talk. There were comments on rounds sometimes. Sometimes even in lectures, you would hear little comments here and there about Indigenous people. Lots of judgments and stereotyping. And again, they all drink. Where are the parents? As Dr. Dumont said, oh, they must be out drinking. And that term "they" was used quite a lot. They don't know how to be a parent. They don't know how to do this. They don't take care of themselves. I would hear that quite often in hallway talk. There was some overt racism as well. But the main forms that I was seeing was these microaggressions and this hallway talk, which was very rampant throughout. And again, not just at the hospital, I would hear it on the street as well. And then it was brought to my attention the issues and things that were going on at diabetes camp. And so I'll just make a brief comment about that. I did eventually, I was the one who approached the organizers of the camp, and two things kind of struck out at me. First was not really realizing that there was a problem with what was going on there, and it took a little bit of discussion to make that more evident. And I think that happens a lot. A lot of people think it's a joke and it's a bit funny, but it's not. And then the other thing that struck me was, they actually did make some changes, and they did listen eventually. And so I'm very happy that things have turned around there. And so, I have actually come full circle. I've actually resigned from the Children's not too long ago, as I've gotten very busy with some other things. And as Dr. Dumont-Maurice, there is a new program. Well, it's no longer new, it's over 10 years now, where we are recruiting medical students, Indigenous students into medicine. And I'm the director of that program. We call it the Indigenous Health Curriculum at the med school. We recruit and support students. And we're actually in charge of teaching about Indigenous health to all medical students as well. And then about 5 years ago, we decided, I'm not sure I'm saying why there's not very many of us, it's me mostly, but I do have some support with the Indigenous Health Professions program. And we decided that we needed to expand beyond just medicine, and we're trying to recruit and support Indigenous students in all the health profession schools. So not just medicine, so nursing, physical therapy, occupational therapy, and speech and language pathology, and even beyond the faculty of medicine. We are working on curricular changes and faculty development, and we're really trying to create a safe space for Indigenous students at McGill, which has not really been the case up until now. Now, the situation in the university setting, it's not perfect. We know that, but Indigenous peoples are now being given a voice. And I really think we're just at the start of our discussions. And, there was a change in the name at McGill, and I think that was very positive. We do have Indigenous trainees, and they are doing well, but they are also experiencing anti-Indigenous racism. I hear about it mostly in the training sites, but I do hear about it in the university in the classroom setting as well. But a little bit more, I'm hearing about it in the training sites. And faculty of medicine and health sciences and some of the training sites are really looking for ways to address these issues. And I think, a discussion like today is really important to get things started. And for me, that sense of pride is returning, and it's returning quite strongly. And I now feel more comfortable in having these discussions with people, whereas, even just 5 or 6 years ago, I would not have felt comfortable with that. So, why am I sharing this? I'm just sharing my story because, as a person, Indigenous person, I didn't really feel that comfortable at the MUHC to talk about these issues. And so why should a person of any race feel that they need to hide or downplay their ethnicity? And so if I was experiencing that in our setting, what are our Indigenous patients experiencing at the MUHC? Do we even think about that much? What are our Indigenous trainees thinking about at the MUHC? And I really want to kind of challenge everyone here as an individual, as a department, and as an institution in general. How can we do better at addressing anti-Indigenous racism? And I think the first step really has to be discussions about recognizing it, because it does exist and it is systemic, it is everywhere. So with that, that's just my story. I'm going to say nyawa. That's thank you in my language. Merci. Thank you. I will come back with a little bit more recommendations to move forward, but I will come back at the end and I will hand things over to Dr. Shaheen-Hussain. Thank you.
Thank you so much, Kent. I'm just going to share my screen, and folks, just give me a second. Okay. Saleem, I can see you as well. Can you just make sure you can see the screen? Yeah, perfect. Thank you. So thank you to the Department of Surgery for this invitation. First of all, it's nice to see so many people out this early in the morning. I just want to first have a disclosure. I have no conflicts of interest to declare, as was mentioned. My name is Samir Shaheen-Hussain. I'm a pediatric emergency physician at the Montreal Children's Hospital. There are some names that I recognize and who are participating here now. So many of us have certainly crossed paths. And recently I also wrote a book on some of these issues, actually. And so my disclosure is tied to that because although I have no conflicts of interest to declare, obviously I did write this book, and but I'd like to highlight or mention that all of my author's royalties from the book are going to be are directed to pre-designated organizations in support of Indigenous children, youth, and their communities. And these are the list of the 6 organizations that that all of my book proceeds are going to already. Before continuing, I also just want to acknowledge the contributions of Cindy Blackstock and Ellen Gabriel, who generously wrote the foreword and the afterword, respectively. And so I always remind people that the book would not be what it is without their contributions. And I'd also like to thank and acknowledge the many families that came out in support of the A Hand to Hold campaign in 2018. I mean, I don't think I need to go into things in too much detail, because at McGill, most people probably know the story, but essentially, there was this non-accompaniment rule that Raven mentioned earlier, where kids from across the province, regardless of where their background, were prevented from having a caregiver accompanying them during emergency medevac airlifts, and that was in practice across the board, and for people living in rural and remote areas. But for those of us, especially at the Children's, who were responsible for Ishi or Cree James Bay Cree territory, as well as Nunavik, we were seeing a lot of these Indigenous kids from northern Quebec coming alone. And as we started digging, we basically realized were disproportionately impacted by this practice. And so that was one of the reasons, essentially, for launching the campaign in 2018. And that made a lot of waves. There was a lot of public support. There was a lot of media coverage. And as I've mentioned in other presentations, it really was, the courageous the courageous stance taken by a lot of these families who themselves were living a really stressful moment with with their kids being sick. But many of these families came out to denounce what they experienced, either in the past or the present, vis-a-vis being kept away from their kids. And then eventually, being allowed to rejoin them. But sometimes that would happen days later because of various reasons. Sometimes, just the weather issues, or there's not enough space on a commercial flight. And so in certain cases, these kids were alone for days at the hospital. So so these families really were the backbone and the soul of the campaign. And I would like to say that it went, without a hitch. It was a smooth process, but the reality is that there were a lot of ups and downs with the campaign. Initially, in fact, there was a flat out refusal from then health minister to change anything. And it took months, but finally in the summer basically of 2018, the provincial government issued a new policy to allow child and family-centered care and allow a caregiver to accompany these kids. And that was across the board. So as a result of the campaign, all kids across the province, regardless of whether they're in Kujarapik or in Gaspé, are now accompanied. But as I mentioned, there were a lot of ups and downs, and I'm just going to share a quick 2-minute video clip just to give a bit of a sense of these ups and downs. This is a news report from 2018, just for background. Sorry, I just don't know why the sound is not coming. I apologize. I had queued this up. Give me 1 second. If it doesn't work, then I'll just keep going. This year. Okay. Sorry about that. I'll basically summarize. So essentially, the clip basically refers to a situation in 2018 when then Health Minister Gaetan Barrette was basically, caught on record saying that he could guarantee that in the next 6 months, there would be a kid who would be sent alone, and that it would make headlines because the parents, were refused, but he guaranteed that this would happen because they would be intoxicated. And so it goes back to the stereotypes that have already been, mentioned earlier. But in the report, in the news story, what's really important is that he basically, the journalist, ask him about it, and he basically says, I'm sorry if I hurt people, or I'm sorry for how my comments were understood, but at the end of the day, can we just move on? And that's a really telling response. I heard it when I was a medical student, a resident and staff, where people often, suggest that Indigenous people basically should, quote unquote, get over it, get over this history and move on. But the reality is that you can't just move on after, in light of ongoing impacts of colonization and genocide. And unfortunately, I don't have time to go through all of these issues, but I do want to address the point of systemic racism, and specifically of medical colonialism. And so in the book, I rely on the work of many people, including Indigenous scholars and activists and families, to frame medical colonialism as a culture or ideology rooted in systemic anti-Indigenous racism that uses medical practices and policies to establish, maintain, and/or advance a genocidal colonial project. I don't have the time to go into it, but what I lay out as an argument is that the medical establishment's role in this could be and should be considered as genocide, as outlined by the United Nations Convention on the Prevention and Punishment of Genocide. And as I outline in the book, each of the 5 acts that constitute, that make up Article 2 of the Convention, there are unfortunately tons of examples that can be looked upon. Historically, and some of these actually continue. And so in the bottom right corner, you'll see the story Les Enfants Volés. That was basically a news report done, an investigative report by Radio-Canada's Enquête program, initially in 2015. And they, they exposed how in the 1950s, 60s, and 70s, Indigenous kids from different communities, Atikamekw Nation, Innu Nation, Anishinaabe, were basically transferred for medical care, and then were disappeared by the medical system, either into foster care, adoption. Some kids died. And to this day, some of these families don't know what happened to those kids and are still searching for the truth. And so you can imagine in that context, with the non-accompaniment rule having started in the 80s, when these kids were being sent up until 2018 alone, there's this huge, long-standing context to that, right? And these kids were sent for all kinds of reasons. There were medical reasons, there were surgical reasons. But for these families and these communities, there was a very, very real concern grounded in historical fact that these kids would just never come back. And so, one of the arguments I make is that the non-accompaniment rule was basically allowed to persist because there is this culture in our work, and I think Raven and Kent have highlighted a little bit already. And we have to, really work actively to recognize that exists. Just a quick anecdote. I did my medical school. I did most of my residency and fellowship training, including in acute care pediatrics at Children's. And it was only in 2017, after almost 10 years of being staff, that I actually decided to do something about it. And so I was obviously complicit in this as well. Basically, this practice that was causing harm to these kids that I'm supposed to be taking care of. And so this was actually a note emailed to me from a former children's pediatric resident a few weeks after the campaign was launched. And she said, I can't even recall all the times in my residency that I was in a situation where this practice or policy affected a child I was taking care of. We knew it was the rule, we knew it was awful, and yet we just kept going. And I guess one of the points, the purposes of writing the book for me is basically to make sure that we no longer just keep going. And at the end of the day, the fight against medical colonialism and systemic racism continues. And I guess I would argue that oftentimes that fight has to be taken outside of hospital walls and clinic walls, and into the streets, and in support of Indigenous-led struggles and movements for autonomy and self-determination, if we actually ever want to meaningfully engage in decolonizing medical and surgical practice. Thank you very much.
I'm just going to share my screen. So I will close it up, and then Kent will speak after me to just finish, bring home the points. So my name is Saleem Razack, and I'm actually a pediatric critical care physician. I don't want to speak on behalf of surgical education. I hope that what I have to say from my perspective as a specialist in a very technologically oriented specialty, and as an educator in that specialty, will hopefully springboard some discussions. And I want you to sort of think about, how does surgical education need to evolve to address issues of systemic racism in surgery? And what would the trainees of tomorrow need to be equipped with in order to do that? The systemic racism in surgery practice, I'm going to give you a pediatric example here. It actually does not pertain to Indigenous people, but it's actually a very big paper that recently came out. And I think that we have no reason to believe that the situation would be any different with Indigenous people. So this is a review of a retrospective review of 172,000 children who had very mundane surgeries, just regular things, TNAs, appendicitis, just usual kinds of things. And this was in the United States. And this was what was compared was sort of the odds ratios and risk ratios for African American children versus white children. And these children were judged to be healthy because they were judged as having ASA category 1 and 2 risks. Yet in terms of mortality risk, it was 3 times greater for African American children, and also risks of complications and so on. And it got me thinking about what are the many different little ways that all of this happens, and what is our role in that, and how is this systemic, and what do we need to teach the next generation. I've been, teaching culture, I'm put it in brackets, for a long time, since 1996. And, now we're in 2021. This slide is a little out of date. But there's been I've had a real evolution in what I think is the right way to teach culture, to teach diversity, to teach difference. And I use the example of these are 3 still life pictures, paintings of fruit. In 1996, with the different fruit in the picture, I would have said, look at the pretty colors. Let's try and appreciate the colors of these different fruits, So I would have been encouraging trainees to be sensitive, culturally aware. And, that is important and is still important. But what's wrong with that is that is a power blind approach. It just sort of treats it as occurring between two people, medical interaction is occurring between 2 different people with, each having agency without thinking about power dynamics. In 2008 or so, let's go to the middle point here. Those of you that are astute will realize that these are tropical fruit now. So I would have said, oh, look at the pretty colors. Some of these fruit are different and they come from somewhere else and they're a bit exotic. But I would have also said that to see this fruit compared to the fruit in the previous picture, maybe I have to shine a different light on it in order to appreciate it better. And that's the idea of competence, cultural competence, learning how to work with an interpreter, for instance, learning what the different modes of communication are in different cultures in order to treat patients better. I think that that's laudable as well, but there's still something lacking there. It makes us think in terms that we can know it all, that we can gain the competencies, we can put residents through OSCEs where they learn these things. I think that is true, but there's still something lacking there. So then now we're in 2021 and we're sort of thinking like, this is a kind of a different painting. So what is the logic of this painting actually? Is it, an expressionist painting? Is it an impressionist painting? Is it modern art painting? And that idea of what is the logic of the system? Why are some colors in the background and some colors are in the foreground? Is, I think, what we need to do today. And that's the idea of cultural safety. So this cultural safety paradigm, it was put forth by Iria Petty Ramsden in 2002. And she was a Maori educator in New Zealand. And for those of you that are wondering, this is a picture of the Treaty of Waitangi, which is to New Zealand what the British North America Act is to Canada. And what she did was she situated healthcare interactions within this history to get us thinking about what happens in the medical encounter and how systemic factors such as colonization and racism affect the medical encounter, asking us to think about why and how interactions occur. The sort of idea here would be that you could say, this appointment began 400 years ago. And what that would do is it would make us think very much about the processes in our institutions and how they, such as what Samir talked about, and how they affect the care received and, in fact, the outcomes of patients. Here's another pediatric example. I think one of the things that I think we do need to teach people is that our institutions, our programs were and are central to the colonization process. So, this is an example of unethical nutrition research that was done in Canada on Aboriginal people, Indigenous people, and on, in fact, on Indigenous children as well. And that the people who did that were parts of our institutions. So I think one of the other things that we need to sort of develop in trainees is the notion of critical consciousness. So what is critical consciousness? It was an idea put forth by Brazilian educator Paulo Freire. And his basic idea was that we recognize that individuals are conscious, reflective social beings and can be made aware of social contradictions and injustice, and they can develop a commitment to act and overcome injustice and oppression. So what we need to teach in this setting is something called structural competence, reading the world. Reading the intensive care unit where we have patients, and what kind of barriers and access issues Indigenous patients are having in that unit, in that moment. But it goes beyond that. It asks us also to commit to act. And, we need to think about what kind of skills we need to develop in surgical trainees, for instance, because we're in a surgical grand rounds, where there's a commitment to act. Another thing, I alluded to the idea of the logic of the system. In 2021, I don't think that you can teach about culture without teaching about the logic of our system. And that is the biggest point for me of now versus then. We need to actually teach trainees that the system is actually designed to be bad to people. It's not benign to people. It's not because something's going wrong. It's actually doing exactly what it's supposed to do. And our healthcare system and our societies in general, our society in general, is built upon anti-Indigenous racism, and it's racially hierarchical. So it also includes anti-Black racism, anti-Semitism and Islamophobia, and the multiple forms of anti-brownness as well. It is also patriarchal. When we teach that women present with MI symptoms atypically in comparison to men, of course we're going to notice healthcare delivery and outcome differences in the treatment and outcomes of myocardial infarction in women. So we have to address patriarchy as well. It's also heteronormative and transphobic, and I believe that our medical education systems are profoundly ableist and and have a great deal of difficulty with disability. Sometimes it comes up, this idea that, because I get asked, okay, we have to think about anti-Indigenous racism, we have to think about anti-Black racism, we have to think about other issues as well. What's more important? And I think the answer is they're all important, and they all have a place, and they all have a struggle that they share, but they also have specificities. So I don't think that in Canada in 2021, we can talk without talking about anti-Indigenous racism. So what we need to do is we need to find the solidarity between struggles and recognize their specificities as well. So what's the way forward? As I said, is to find the solidarity in many specificities. And I hope I've gotten you thinking a little bit about where surgical education has to go. I'd be very interested in your thoughts as we have chance for questions. And now I pass it over to Kent, and I will stop my share.
Thank you, Saleem. I just have a few slides to go through to finish up here. And just a few recommendations to move forward. You know, there's many different things that we could talk about, but just a few things to start. This is really things just to start. And so there are numerous calls to action that have taken place, and if you probably have heard about them, but maybe aren't aware of some of the recommendations that are there. There's too many to go through, but there's the Truth and Reconciliation Commission findings that came out in 2015, and then there was the Vienne Commission, specifically in Quebec, that had some strong recommendations as well just a few years ago, and numerous calls to action regarding health in both. And one of those big recommendations was to increase the knowledge and training on Indigenous health for all trainees, all faculty and staff. And this would really address you know, those things that I saw early on when I came back. Just people just do not know. And it's not just the physicians and nurses. It really goes right down to the receptionists who are greeting our patients. These our institutions are really not culturally safe spaces, and the care we're providing sometimes is safe, sometimes is not. And those are some of the big things that we need to look at. How do we do that? And as individuals, I actually encourage you to take a look at this four-part documentary series, which is available online. It's called Eighth Fire. It's a little bit outdated. It's from 9 years ago. The fellow you see there is Wab Canoe, who was working for CBC at the time. He's Anishinaabe, and he's in politics now. But the four-part series is actually quite well done, and it gives you some idea of the issues that Indigenous people are facing here in Canada. You could find it easily online. For those of you who are looking for some academic journals that can help give you some direction, I would direct you towards the SOGC journal. They came out with a whole theme journal in 2013, Health Professionals Working with First Nations, Inuit, and Métis Consensus Guidelines. There's also a paper written by Allen and Smiley, came out in 2015, called First People Second Class Treatment. Again, easily you can find it easily online. And there are online resources. One example is the Sanyas Indigenous Cultural Training. Now that one is quite in depth, and there is a fee for that. And I think there's about 8 different modules, but it's extremely thorough in trying to help you become a culturally safe provider. Now at the MUHC, there are some changes that have taken place, but there is room for a lot more. There is a lecture series that goes on. It's called the Indigenous Health, History, and Culture series. And you probably all are getting emails advertising that. It's about 1 lecture every second month during usually September to May or so. And it's quite well done. I encourage you to participate in that. At the MUHC, I do think we need more Indigenous spaces. We were approached many years ago to consider a smudging room at the MUHC. We did approach the administration. It did not happen. But I do think there's a lot more room for that. And for people who are in the trainee program, for your residents, do you have a plan in place to increase that diversity? Do you have a plan in place to get more Indigenous trainees? And if you're hiring faculty and staff, what policies are in place to get more Indigenous trainees? Because we really need more people. And what is the MUHC doing in general? I do think there is a committee on anti-racism right now, but I do think, would the MUHC accept Joyce's principle? I don't really know. And this is my final slide. It's really a challenge to everyone. Very often we think about Indigenous people and we think about all the difficulties and how hard it is to treat them. And but how can we shift that? How can we shift to be more positive about Indigenous peoples? And with that, I'll just say thank you again. And we have just a few minutes left for some questions and discussion. Thank you.
Well, thank you, all of you, for that pretty, how should I guess in many ways, difficult discussion that you've brought up. Many experiences there, I guess, that a lot of us can't really understand fully. And so I'd like to thank you for sharing that with us and for giving us some challenges. I think there are a lot of challenges there in trying to treat Indigenous people, but also perhaps, you know, at a larger area, a larger envelope of all different types of people. And I think, you know, when we first thought about having the group come and speak to us, I mean, we certainly in surgery, I think, want to, you know, we have a problem, we try to fix it. And, you know, I think personally, you know, it doesn't really matter who you are, we just want to fix the problem and have the best outcome possible. But obviously there are other issues around doing that. So I guess I'm just going to leave the group. Maybe if there are any questions that come up, and I don't know if maybe Dr. Feldman has her hand up, and I'm sure she wants to comment. So I'll just let her.
I always have my hand up. No, I just, you know, as the department chair, I really want to thank each of you, Dr. Dumont-Maurice. I think I saw her with her little baby there, Dr. Saylor, Dr. Shaheen-Hussain, and Dr. Razack, for taking the time and really sharing your stories, very personal stories in many cases, and not easy to share personal stories. But I think those are the kinds of things that really resonate with people and inspire people. So I really appreciate that you're able to share the emotions and share the experiences that we need to hear. And because I think those stories are what people remember when it gets tied to the emotion of personal experiences of people that we of our colleagues and of our patients. And I think that as surgeons, you know, we treat people at some of their most vulnerable times of their lives. And I think that that's something that we honor, and that's a very important value for us. So I appreciate as well the recommendations and the opportunities for further learning as individuals, but I agree that we have to address the power we have and the position we have in a system. And I think that's the charge for us today, in addition to our personal learning. And this is a great first step and for us. And I think we had a very good turnout. You know, we have many of people who watch together, physically distanced, of course. But so I think we probably had over 100 people listening today, which for our surgical grand rounds is a very good turnout. I will look forward to posting the talk as well. I think everybody in our department, all trainees and all of our faculty need to see this talk, and to think about our individual roles and our roles as faculty and as people with power here. So I really appreciate that again, and taking the time, and lots of food for thought. So thank you.
I just, there's a comment here on the chat by Roger Taba. Fabulous talk. Best experience of my residency was 4 months at Moose Factory Hospital. Taught me so much about Indigenous culture. So a lot of us, I guess some of us have a very good experience with that. So there you go. Yes, Hussein.
Hi, my name is Hussein Musanji. I'm a pediatric surgeon at the Children's Hospital. I wanted to thank the speaker immensely for this talk. I think it's amazing that we were able to present this at a surgical round. Change begins with compassion and understanding the other. And that requires sometimes to share your story and to give a historical background to understand where people come from. So thank you very much for doing this. It must not have been easy. I wanted to, at the Children's here, in the Division of Pediatric Surgery, we started to do systemic research on systemic inequalities in Canadian healthcare. Dr. Razack, the paper you've published is one of the many American papers, but we don't have so much data in Canada. And the goal is really to influence policy, and as well as understanding better if people don't have similar outcomes or the guidelines are not respected in pediatric surgery if you come from a minority group. I wanted to know, do you have any other suggestion or topics for how to influence change and how to have actionable tools to address this issue?
Maybe I'll start, because I think Samir and Raven and Kent have a lot to say about this as well. But it seems to me that to move people in medicine, you need to present good data. So the idea of studying our situation here in Canada is really, really laudable. And I think that, I can only speak for myself as a Canadian, but, I grew up watching TV from Buffalo, New York, and thinking that all the racism happened in US rather than in Canada. And I think that that is one thing that has changed, and is a call to action for us to study our own situation. But I don't think we can do any of this without communities that we work with. And I'll leave it to my colleagues to comment on that part of it and anything else.
Yeah, the only thing I would say is maybe do you actually know the outcomes of your patients and how your patients are feeling about the care that they receive? And are there any, I don't know if the word would be exit interviews or something like that, some small survey to start about how did you feel about the care that you received? And maybe comparing the Indigenous patients to the non-Indigenous patients, that would be a place to start. But I really always encourage starting at the very beginning of just really in educating yourselves more, because really there is a lot of things people do not know. Do you even know if you're seeing a Cree patient or an Inuit patient when you see them? A lot of people don't know the differences, and culturally they are so different, and their beliefs about different things and their beliefs about surgery in general might be very different. So I kind of really put a plug for both things. I think increasing the education is very key, but maybe asking patients how their experiences were would be another place to start as well.
Yeah, hi. So I'll chime in quickly as well. River is she might have a few words she can say about 20 now. So very similarly to Kent, I think basic education that hasn't traditionally been taught even K to grade 12, and so there's an overall mission in understanding, and sometimes that education from the Indigenous perspective is important as well in understanding. And we spoke to research, and advancing in medicine often needs data and numbers and research for sure. But there are certain things always to consider in doing research with Indigenous peoples. Who owns the data? What are we going to do with the data? And there are guidelines out there called the OCAP principles. Going forward, if ever this is an interest, but I would invite anybody to look at those if there's certainly an interest there. And thank you. That's my 2 cents.
I can chime in really quickly. Thanks for the question, Hussain. There's a lot to say, but one of the things I think, it's just kind of this really tough situation where even for something, let's say like the non-accompaniment rule, right? Like this was something that everyone could agree was just horrific. Any of our colleagues, when we would talk about it, everyone would be like, I can't imagine my child being ripped away from me and sent down. And yet, like some things are just intuitive, I guess, right? And sometimes it just becomes frustrating, I find, to have to prove it with research. Unfortunately, it's what's necessary sometimes. But I guess one of the core issues is really, I think, like Kent mentioned and Raven mentioned and Saleem, is really listening to what people are saying. And I think historically, that's something that we have not done. at all, including for these, in terms of the non-accompaniment rule, there were Inuit communities that were starting since the 1990s to try to change things, right? And those requests are just completely ignored over years. And so, and then the other element in terms of research that becomes difficult is in Canada, most institutions don't really collect race-based data, which on the one hand can make sense because race as a biological entity doesn't exist, but it obviously undermines a lot of the work that we're trying to do when we know that people are going to be impacted based on the color of their skin or their ethnicity or the language they speak. And so I think that too is a challenge internally that we really have to, I guess, push. But going back to points that Raven and Kent and others have made, I do think as departments, as faculties, we really need to adopt Joyce's principle. That's something we can tangibly do in Quebec. The government is not gonna allow that to happen until institutions and individuals push for it. And so I really feel like if we do that, there will actually be tangible changes. And one thing that's important to keep in mind is just like with the non-accompaniment rule in the campaign, when we won the campaign, it actually impacted kids across the province, regardless of where they were from. Obviously, we centered the reality of Indigenous kids, but it impacted everyone. And same thing with Joyce's principle. If those principles are adopted, healthcare in general is just going to be much, much, much better and more dignified.
Thank you so much for the answers, and we fully agree. I fully agree with the participation and being non-prescriptive with recommendations. And we've had the pleasure to learn a lot and involve Indigenous patients in our research as knowledge users, and also as co-authors on papers. So this is really, really the way we want to go forward to understand better and not be prescriptive. Thanks.
Well, thank you everybody for great talks and a lot of food for thought, obviously. So I don't know if Dr. Feldman has any parting words.
No, just again, appreciate your time. I think sometimes it's hard on Zoom to get a sense of that you're speaking to somebody, but there are a lot of human beings who listened to what you said this morning and greatly appreciated your time and willingness to share with us. Thank you. And have a great day. Bye.